I would like to thank the organizers for inviting me to this conference. It's not my first time. I've been here several times, and I always enjoying meeting with the colleagues from Egypt because I really admire your work, and I've learned a lot. And I think that's really very nice that you have this special congresses on bronchoscopy and bronchology, because I think it's really worth it, and we have to share experience. And as we had the opportunity to hear this morning, this field is not done. It's still developing. There are so many new techniques, new advances, mostly always starting with adults, but slowly then moving also into the pediatric age. So we will see definitely in the future even more pediatric new techniques and things that will help us to diagnose properly what's going on in the children. I must say that I'm really enjoying being again in Cairo. My suitcase is still enjoying Munich apparently, so excuse me, I just arrived with one t-shirt and the jeans, and the suitcase is supposed to follow within the next days. So yeah, I hope it does not change anything with my presentation, but I was asked to cover some conditions that can mimic asthma, because I think this is a very crucial thing. Within the care of asthma, there are so many possibilities to be really misleaded and to have inappropriate diagnosis, and children are sometimes over-treated unnecessarily, but sometimes also under-treated when asthma is not diagnosed properly. Of course, we don't need to repeat what asthma is, but I would just point out that asthma is a chronic condition which is characterized by a reversible or partly reversible airway obstruction, and that's where it all develops from, because if we talk about the clinical symptoms, they are mostly based on this obstruction. And if we have other causes of obstruction, it can happen that the differential diagnosis becomes less easy, becomes more complicated, and we have to confirm that there is everything okay, that there is no other reason for obstruction. And also for the diagnosis of asthma, you know that we are trying to, at least clinically, confirm that there is some degree of inflammation or maybe even some remodeling. Asthma definitely exists, and it is a real obstruction, and you can see on the screen what obstruction in asthma is. And I would like to remind you that asthma is not just the obstruction of some lost very far away peripheral airways. It is an obstruction of the whole bronchial tree, and because this, what you see on this a little bit accelerated video, this is a bronchospasm occurring in the orifice of the right middle lobe bronchus. So it's really the level of like third division, and this is where actually the bronchial resistance is formed. These are the large airways more than the peripheral airways. So patients are feeling the obstruction more when they have the obstruction of these central airways compared to the real peripheral regions. And you see that during the bronchospasm there is also some swelling, some redness, some hyperemia. So this is what is really happening with asthma. So we have to differentiate this type of obstruction from the other types of possible obstruction that can happen in children, but also in adults. Clinical symptoms in children are mostly wheezing and coughing. We don't hear from kids so much about chest tightness, and which can be sometimes the only symptom in adults. But we hear more than in adults about exercise-induced symptoms. So that's all the clinical work that we have to do. And I think one of the crucial things is to really make sure that we see the real clinical picture, that we know what we are talking about. Of course, the diagnosis of asthma is based on the bronchial hyperresponsiveness mostly. So we do the challenge test, we do the exercise challenge, we do the metacholine challenge. We are hoping to do some osmotic challenges like mannitol. But we also want to prove that there is some inflammation, and we can imagine that with this degree of remodeling which we see on these panels, where there is so much newly formed smooth muscle, we definitely will have more bronchial hyperresponsiveness than in other conditions. So if we want to confirm asthma and differentiate asthma from other diagnoses, we sometimes use also the bronchial biopsy to confirm the remodeling, the thickening of the basement membrane, which you can see on the right-hand panel over there, and the degree of inflammation, but also we look at the quantity of the smooth muscle, and you see that in these pediatric biopsies from our work, the smooth muscle is really very much hyperplastic, and you can imagine that this will determine the very significant bronchial hyperresponsiveness. It is more and more difficult to differentiate asthma from other conditions in very small kids. We have a growing number of kids who experience at least some type of wheezing, and it's said from some studies that up to 50% of children younger than 5 experience at least one episode of clinically detectable wheezing. And so we have to be very sure that we are starting the treatment in children who really need it, and that we have excluded other conditions. What is of course always very much necessary is to do the appropriate clinical evaluation of the whole situation. So, and the situation is characterized by the symptoms, the presentation and sound characteristics, which is very critical. Also we look at the triggering mechanisms where possibly when the parents visit a grandma with a kid, and the grandma has a whole lot of cats, and the child is starting to wheeze once entering the room and with the grandmother and the cats, then you have a challenge chamber, and you have actually a positive inhalation challenge to the cat allergen maybe, or maybe to the grandma allergen. So depending on what's going on there, you can characterize the symptoms. You want to look at the frequency of the symptoms. Of course, you look at the reversibility, and sometimes the answer, what we were looking at, is given only by the long-term course, but we hope to find out earlier than so we don't need to wait so much time before really confirming the diagnosis. I see a very critical part in the clinical interpretation of the sound characteristics of the wheezing or the symptoms. And we know that the caregivers or parents or whoever is presenting with the child are sometimes misinterpreting the symptoms. And you definitely know that from your offices, that they are coming and saying that the child has some strange symptoms, there is some wheezing or whatever, and they describe strange things. But you don't see it because the child is okay when it's in your office. So I think the critical thing is to try to objectively confirm what's really going on. And we've seen kids who were treated for asthma, and it was a nasal wheezing with some stenosis of the nasal passages. We've seen misinterpreting wheezing and snoring. We've seen the stridor interpreted as asthma and really treated by general practitioner by steroids. So what we need to do is to see the child with the symptoms. And that's not that easy, because you sometimes hear from the parents that it happens only on certain days, certain nights, triggered by certain situations, and you don't want to sit with the child at their home for 1 week and wait for the symptoms. So what we have developed in my place is that we are using the new advances in the technologies, which you all have. And I'm pretty sure that every one of you has a video camera in a pocket now. Is that right? Almost everyone has a mobile phone with a possibility of recording. So what we did is that we suggest to the parents to record the symptoms when they occur. They use either the real video camera, or they can use just the mobile phone. And I must say that I remember from the last year, we have like 5 or 6 cases where, based just on the mobile phone recording, we excluded asthma in about 5, maybe 6 children. It's really quite useful. Or you can use just the dictation device, but you would like to see the chat as well, so the video is much better than just a simple sound. So we had even the child who was over-treated for refractory asthma, over-treated with inhaled steroids with very high doses that led even to adrenal suppression. And when we looked at the video that the mother provided later on, we found that it was really negligible, really no obstructive symptoms. It was just some type of something like this done during the night, which was scaring the mother, and she always reported to the doctor that the child is suffocating at night, and the doctor kept increasing the inhaled steroids. When we saw this video, we said, please, just don't touch the child, it will go away, and it's nothing. It's just what we all do almost, yeah, during the night, but we are not recorded during that, or the parents don't care so much about us. If we look at the differential diagnosis of childhood wheezing, there is a whole lot of things that we have to consider. Of course, even within asthma, there are different phenotypes that we have to consider, and we have definitely different types of bronchial obstruction based on so-called asthma, where the real bronchoconstriction is present. It's like viral wheezing, we have the exercise-induced wheezing, and we have the allergic wheezing if we look at the phenotypes as they have been characterized by the Practal initiative. We have, in small kids, we have bronchiolitis that can be sometimes misinterpreted as asthma, and we know that in bronchiolitis steroids don't help so much, and that after bronchiolitis maybe the leukotriene antagonist would be useful in some kids. But we also have some anatomical conditions that can be presenting with obstructive symptoms and even expiratory obstructive symptoms, which again could be suggestive of asthma. Especially in pediatrics, the congenital airway malformations like rings and external compressions come into the question, because this is the time period where these things present, and then they have to be dealt with. Of course, foreign body aspiration is one of the possibilities, and we've seen kids who were presenting as sort of asthmatic attack, and they have aspirated like nuts or so. Aspirations of other stuff like food or fluids, gastroesophageal reflux, or some swallowing discoordination can lead to these conditions. Of course, all kids with a BPD or the history of extreme prematurity have some type of bronchial hyperresponsiveness, and we've seen even kids with cystic fibrosis who were misdiagnosed as asthma and have been treated for several years as asthma until they really developed an advanced CF disease, and it was almost too late to start some effective treatment. A very special condition is the vocal cord dysfunction occurring in the later school age and in the adolescence, which has been interpreted as asthma for really many times. And if you look at the differential diagnosis, for instance, in terms of initiating biological treatment in the difficult to treat asthma, vocal cord dysfunction is one of the entities that has always to be excluded. And we've seen also kids who were overtreated for vocal cord dysfunction when they were overtreated with steroids being characterized as a non-responsive asthma. Immunodeficiencies with the chronic inflammation can have some of these, and primary ciliary dyskinesia very frequently has some degree of bronchial hyperresponsiveness and can also have some obstructive symptoms in addition to these all infectious symptoms and mucus or mucus production. We can help ourselves a little bit with the age, and if you look at the age of the child, we have some probabilities. Of course, asthma can occur in any age, but it's very rare in real infants that it is a clear-cut expressed asthma. We've seen kids like that, but it is not that usual as in the older ages. So certainly we have to consider with the first obstruction or first wheezing in this low age group, we have to consider congenital airway malformation or vascular malformation, compression, malacia, even the bronchiolitis maybe, which should have a separate clinical presentation. CF can present with obstruction or these aspiration syndromes. When they are a little bit older, asthma is already coming into account, and it's getting there, and you know from the phenotypic characterization that the real asthma mostly occurs at the age of about between 18 to like 36 months with the first wheezing associated with atopy. CF, aspiration, and the PCD starts to be on the list from this age group. In the older preschool kids, asthma is already on the top of the list, but there are still other possibilities. We mostly do not diagnose the congenital malformations at this age, but we should look for the CF and aspiration and PCD. And in school kids, asthma is definitely the most frequent one. Again, still the others remaining on the list, and but it's a shame when you diagnose cystic fibrosis only at the school age or even late school age. It should be done much earlier, and that's why many countries have now introduced the neonatal screening, which is very helpful in this, and that should really shift the diagnosis to the very low age groups where we have the opportunity to still intervene and delay the thing. This guy is Jose Castro Rodriguez. You may know the name. This is the guy from the, who at a certain time worked with Fernando Martinez in the Tussen group, and he defined a very nice clinical predictive index that can help us in the differential diagnosis of some children presenting with bronchial obstruction. And he actually defined this mainly for the kids with frequent obstructive episodes, like 4 and more events a year in kids 2 to 3 years old, but then it was extended even to 4 years old. But let's say the preschool kids with a repeated presentation of obstruction. And if they have one this obstruction and one major risk factor, or 2 or more minor risk factors, the probability of this being asthma is already in the range of about 80%. So what do we do for diagnosis? We should definitely work mainly on a clinical basis. So we should work on the family and personal history. Physical examination is not extremely helpful. It is mostly helpful for excluding other things, but if you see the child outside the symptom period, you mostly don't see anything. So what if you can help yourself with this recording or with some other methods, but or you see, if you are lucky and you really see it during the symptomatic period, the physical examination can help, but otherwise it's not very useful. Allergic testing, chest x-ray, of course. We try to do the PFT in the kids even as young as 3. You know that from the literature it's mostly said that pulmonary function testing is possible from 5 or 6 years of age. It's really not true. If you have a little bit cooperating child and a good technician, you can shift it down to like 3 years, 3.5 years, and we even have 2.5 years olds who do proper flow volume loop if you take time and if you really play with them and you make it a game. And then we go for the differential diagnosis, and certainly, and we are at the bronchoscopy congress, I remind you, certainly bronchoscopy has a very important role. It's not on the top of the list, but it is there, and the threshold for bronchoscopy should not be too high. We should consider bronchoscopy whenever we suspect there is something wrong, there is poor reversibility, or the clinical symptoms do suggest some other entity, not just a variable bronchial obstruction characteristic for asthma. What is very important is the technique how the bronchoscopy would be done in these children, especially in these children where we expect some changes with the fluctuation of the intrathoracic pressure, some changing of the patency of the airways. We certainly must keep the child breathing. The anesthesia, analgesia, whatever you use, must not interfere with the normal breathing, because then you have the normal changes of the intrathoracic pressures, and the intrathoracic pressure is affecting the airways, and you see the real situation. Once you have the relaxation, once you have the positive pressure ventilation, you miss 80% of the information in these kids. So certainly what we do is that we either use the real analgous sedation, combining midazolam and maybe some of the fentanyl derivatives, keeping the child just in the conscious sedation, or we use the general anesthesia using propofol and sevoflurane, but without any muscle relaxation and still preserving the spontaneous breathing. Certainly the child must be bronchoscoped with as little interference with the breathing as possible. So we definitely do the nasal approach. We look from a distance. We try not to interfere with the larynx, and then we slowly advance through the cords, and we look at the airways during the breathing. There are still some places where people, or maybe mainly anesthetists, are afraid of this approach, and they try to intubate the child and then do the bronchoscopy through the tube. That's a nonsense. That's really a very bad thing to do, because they can miss a lot. They don't see the larynx, they don't see the subglottic area, they don't see the fluctuations of the trachea. So I'm really very angry at these people, and we have one place in our country where the pediatric pulmonologists don't do the bronchoscopy, and they ask always the adults to do that for them, and they just come as a service with their anesthetist, and their anesthetists are afraid of kids. So they intubate, they say, be as quick as possible, take your material and go back. So that's a nonsense. That's a very unuseful bronchoscopy, and the only opportunity where you want to intubate or maybe use the laryngeal mask is when you really need just to sample material, like in immunocompromised kids, and you are not so much interested in the anatomy. But once you need the full information, even the laryngeal mask is interfering with the breathing, and I think we need to know that, and that must be really in every course, in every teaching, this should be pointed out. Of course, we need some situations where we need the cooperation of the child. I will show you one example later on. And then we of course do also some other tests. We are using the opportunity of entering the airways for the full differential diagnosis. So the bronchoalveolar lavage and mucosal biopsy is a mandatory. Even the bronchial biopsy, if you consider asthma, can be very helpful if you have a good pathologist and if you know what you are looking for. So we do that almost in everyone, just to make sure that we are not missing any information. All right, let's look at some of the findings. We can see this is a child who was diagnosed as asthma, quite young child, about 1 year old. It was a child who was originally immature and had a immature trachea, and you see there is a very severe tracheomalacia, the real tracheomalacia, and you see even the chronic changes here in the peripheral airways where the mucus was stagnating and there was a chronic inflammation. So this child certainly had no asthma. This was a child who had mechanical obstruction that was interfering with the mucus clearance, and this child needed some continuous antibiotic, and for a while we used also the CPAP to keep the airways open, and we gave the child the opportunity to get more mature trachea and to stabilize the trachea with the growth, and it really helped. So we did not interfere. We are trying to avoid any stenting, any surgical intervention, because it's usually doing more harm in these kids than some benefit. This is the case where I really used conscious sedation deliberately, and I asked the child for a full cooperation. It was a 12-year-old guy who actually was treated for refractory asthma, and the story was that about 2 years or 3 years before we saw him, he had some respiratory infection, and somebody somehow decided to do the spirometry on him. So they did the spirometry, and he presented with something like this. This is my painting, but sorry about my drawing of the curve, but sorry about it. But it's just characterizing what it looked like about approximately. So there was some obstructive pattern of the flow volume loop, and that was interpreted as an obstruction, no reversibility. The child was put on. I just remind you that he had mild respiratory infection, no other symptoms. This infection went away. The child was symptom-free, but the spirometry kept the same. So the doctors started him on inhaled steroids. It did not help. So they increased the inhaled steroids. If this did not help, they increased again and again and again, and the child ended up on systemic steroids with full load of bronchodilating treatment, and it did not help. The spirometry remained the same. So it was referred to our Center for Severe Asthma as a refractory asthma for further differential diagnosis. When I looked at the curve and I looked at the child, I already got the suspicion that something really was wrong. So what I did was that he was quite good. He was 10 or 12 when we saw him actually, and I asked him for a full cooperation. We gave some alfentanil and midazolam, and he really worked very well with us. And I asked him to repeat the maneuver he did during the spirometry with the bronchoscope inserted into the airways. And this is what actually he presented with. If I can get it moving. All right, I should. Just look at the posterior wall of the trachea. Now there is some coughing. The coughing is not really very apparent. It's doing nothing very special. But this is the forced expiration. Inspiration, expiration. Inspiration, you see, expiration. It's increased sort of inward collapsibility of the posterior wall, but it appeared only during the real forced expiration, which is a very unusual situation. You don't do these maneuvers during your everyday life. So we stopped all the treatment. I even took a biopsy from him, and it was completely normal. There was just some chronic inflammation, but really no asthmatic changes. So we stopped the treatment altogether, and the child actually had no asthma. It was really just mechanical compression during the forced expiration, and the child was treated with steroids for several years for that. So I think we should be always suspicious that we are missing something. Very special category are the vascular compressions or interference of the vascular structures with the airways, and you see that actually there is lots of opportunity of interference there because where there is a trachea and the main bronchi, there is a whole lot of different large vessels that can be shifted a little bit. There can be some anomalies. There can be even some dilation maybe of the pulmonary artery or so. So these are things that should be considered, and we should know the anatomy, and we should know, doing the bronchoscopy, we should know properly the external anatomy outside the airways to make sure that we are not missing anything and that we know what this could work or whatever. But we should follow the lung function of children after viral pneumonias and viral bronchiolitis as soon as possible, because we might detect these changes very early on once they start occurring, and then we might interfere with maybe some high-dose steroids or something. But we still don't know, because this is quite a new finding that I know 3 places in the world where people do these endoscopies and try to visualize these. So we will probably share the data, and we will try to publish some suggestive information on it. So to conclude, if we talk about bronchial obstruction in children, it's usually asthma. But it is not always asthma, and we should be very careful of what we are treating and how we are treating. So we should always go for appropriate characteristics of symptoms and sounds, and I suggest to you to use the mobile phones or whatever possibility of recording. We should do the functional analysis if possible and applicable, and we should start very early on. Maybe the first spirometry will be unsuccessful, but the next already would have some effect of the training of the first spirometry, so maybe you can get a reliable lung function, or at least orient yourself by some partly reliable lung function test at the age of 3. The threshold for an indication of bronchoscopy should not be high. Bronchoscopy nowadays is a very safe method, and it's much safer to do the bronchoscopy and find a normal finding than to treat the child for several years with high-dose steroids because we did not know. So of course we don't use it as a first-line diagnostic tool, but we use it quite low in the row. If it's done, then it must be done with the knowledge. Appropriate sedation, appropriate preserved breathing, always be ready for sampling material, not to be surprised by anything, so be ready for extraction of foreign body, be ready for the biopsy, be ready for the lavage. And again, diagnosis of asthma in a child who's wheezing is the most probable one. The frequency of asthma is much higher than of anything else, but it's not always asthma, and we should always question our conclusions when something is wrong and something doesn't fit into the idea. So this is what the Czech Republic starts looking like now. We have snow, it's freezing. My flight was delayed because of cleaning of the airport, so I envy you your warm temperature in Cairo, and because my suitcase is freezing in Munich, and I'm enjoying it with you. Thank you very much.
Thank you very much, Professor Bohunik. I think we only have maybe room for 2 questions, so I will ask the first question. Concerning the patients with the bronchitis or the bronchiolitis obliterans, or the patients who had an inflammatory, how do you think a pre- and post-bronchodilator pulmonary function or spirometry would help to avoid using steroids, for such a long time?
It's interesting that these children sometimes respond a little bit to the administration of bronchodilation. They do have some very mild reversibility, but it's definitely never exceeding like 5-10% or something. It's never really significant. But interestingly, it is there. So we even tried to treat these kids with some, combination therapy, like Symbicort or Seretide, and they actually presented with some small improvement. But certainly the reversibility is really poor. So if you have this patient with lung function like this, and it would be asthma, you would expect a little bit more. Or you can try then with the steroids, with the real oral steroids or something, just to try to induce reversibility. These kids would not respond. Asthma kids probably would respond a little bit better. So say again,
many patients CB and having seizure disorder and having vocal cord dysfunction and having pseudobulbar picture. No any future plan or management?
You mean the VCD?
Yes,
The management is not easy, I say. Sometimes when they, depending on the level of psychopathology that's involved actually, they must want to get rid of it. Some of them don't want to really get rid of it because they are somehow embedded in it and they're enjoying being the center of the focus of the whole environment. So what is standard and recommended mainly by the Denver group from National Jewish who described this and who did probably the most work on it, the speech therapist should be involved from the very beginning, and they do a special laryngeal training for these kids to try to reverse this pathological mechanism. I was successful several times just with myself. I'm not an expert, I'm not a phoniater, I'm not a speech therapist, but I was successful just with trying to explain them the problem and trying to start some training with a little bit forced expiration against some pressure, some resistance, like balloon inflation or whatever, that can sometimes help to appropriately retrain the appropriate phasing of the larynx. But it is sometimes really tricky. It could take a lot of time. Certainly what you must do from the very beginning is to exclude gastroesophageal reflux or treat it and check what is the real level of their asthma, if there is any, and keep them on some maybe low-level anti-asthma treatment to prevent some asthmatic feelings that could reinduce these laryngeal pathology as well.
Nowadays also there is Baker classification for severity of asthma. Mentioned Rogers and then many pediatric emergencies for the Baker classifications. Having a role now. Baker classifications of the severity of the asthma, Baker's.
Yeah, I think, you know, this, these findings in the non-asthma obstruction mostly do not fit into any classification, because you don't have the typical pattern of the symptoms. You don't have the nocturnal symptoms like you have in the classification systems. You don't have sometimes the exercise-induced asthma. So it always looks a little bit strange. It does not fit into the standard approach. So it can look like, you know, a real severe suffocation with the vocal cord dysfunction, for instance, and but it does not fit with the other symptoms. The symptoms are not that frequent, or the lung function has not changed, so there are always some discrepancies. So once there is some discrepancy, you should go deep into it and try to diagnose.
Thank you very much, Professor Bohunik. And now I declare the session closed. We are now opening the floor for the following session on sleep medicine.
Thank you very much for coming.